Hi, everyone. Thank you for joining and welcome to Topics in Surgical Informatics, which is our journal club here at the Surgical Informatics Lab. Today, we usually feature super interesting papers, and today we have the opportunity to have the authors from this innovative piece called Intraoperative Surgical Guidance for Deep Flap Harvest using Augmented Reality. So I'll go ahead and introduce Dr. Kathryn Isaac. Thank you so much for being here. Dr. Philip Edgcumbe and Tony Jiang, who we didn't know was joining, but we're very excited to have too. So thank you all for making the time. So to give everyone some background and be on the same page, we'll share our view of the presentation shortly, and then we'll allow time for you to give any insight or anything that wasn't mentioned in the paper. So the deep flap is the preferred technique for autologous breast
And
reconstruction.
sorry to interrupt. One tiny thing also, feel free at any point
Yeah.
if you have, sometimes we found that authors have really great insights into differences in the methodology or insights into how some of the data was captured or even analyzed. So feel free to interrupt at any time, please.
Thank you, Dr. Brat. Exactly. So the deep flap is the preferred technique for autologous breast reconstruction. It involves transferring skin and fat from the abdomen into the breast to reconstruct the breast. In doing so, it is important to preserve the vessels that supply this tissue to ensure the success of the process. Conventionally, CTA is used to do this to preoperatively map the perforators. However, this lacks real-time guidance during the surgery, and this is where augmented reality emerges as a promising opportunity to project the 3D vascular anatomy directly onto the patient and assist in intraoperative guidance. The goal of this paper was to evaluate the use of the MetaQuest 3 augmented reality headset for intraoperative guidance in deep flap. So the paper reports the finding from 3 clinical cases of deep flap surgery where they preoperatively use the augmented reality to project the CTA on the skin and draw the perforator vascular directly onto the skin. And then they use it again intraoperatively to mark the fascia for vessel dissection. Our workflow is amazing. Your workflow, sorry, it's amazing. So we wanted to give the steps because it's super innovative. So first, you need to get the preoperative CTA. Before the scan, temporary tattoos and metal fiducials are placed on key anatomical landmarks like the xiphoid process and so on. Once you obtain the CTA, they segmented this one using the ITKey Snap software, and they segmented the CTA on key anatomical structures like the external iliac arteries, the deep inferior epigastric arteries, the rectus abdominal muscles, and abdominal fat. This will allow for later separation of each anatomical layer when using the device. Then an important step is the development of the application. The team developed a custom augmented reality application in Unity, and this application allows surgeons to view and manipulate. It allows surgeons to create models specific to the patient based on their CTA, and once they have it, they can manipulate wearing the headset and study the anatomy preoperatively. The app is very user-friendly and intuitive. It enables gesture controls to scroll through the CTAs, to adjust the opacity, and also to unfreeze or unfreeze the models. And it runs on the Quest 3 video pass-through. And this is a picture of when they were developing the app. And this is a screenshot wearing the headset of how the patient models are created and manipulated by the user wearing the device. Next, a very important step is this model projecting it onto the patient, and this requires 2 registration process. The first one, the surgeon will wear the headset, which has hand tracking type of capabilities, and will touch each tattoo that was marked on the patient with their index finger, and the headset will track this, and this aligns the 3D scan onto the patient. This has a reprojection error, meaning the distance between the expected landmark and the projection of 6.5 millimeters. However, they move on to a second step, which is manual fine-tuning. The adjustments are made along the X, Y, and Z axis to better align the anatomy. And after doing this, they achieve a 1.3 millimeter reprojection error. considering the average perforator diameter is between 2.1 to 2.9 millimeters, this reprojection error is super acceptable to locate the vessels. And here are some pictures of how they study this in manicky models. And you can see here the final picture when they achieve the 1.3 millimeter reprojection error. The gray dots are where the fiducials were placed, and the red dots are the projection. Next, the app is ready and the process is ready for the preoperative use of the augmented reality. What they did is they use a headset to, again, project the vascular onto the skin and to mark the abdomen for specifically the entry and exit points of the vessels. Once in the surgery, the headset is worn again when the flap is raised and the fascia is exposed to allow for augmented reality overlay. The augmented reality overlay, helps mark the rectus fascia where the perforator runs. And the surgeons can use their hand gestures to adjust the opacity, to scroll through the CT slices, and to toggle with the anatomical layers. And these are 3 amazing pictures the paper includes, featuring the uses of this device intraoperatively. As we can see, the device has these hand tracking capabilities, which enable surgeons to use their hands and to not need any metal placement, any QR code, which that is also super important in the intraoperative settings. So as a summary, what they use is the hardware, which are the MetaQuest, which are about $500. The software, which was used for the pre-op CTA segmentation via AT-key snap. The app, which was custom app developed in Unity, and the registration process, which as described. The conclusions, this paper shows the potential to improve flap designs, to reduce dissection time, and to improve safety. The authors, one their future works for this author is to measure the impact on surgical efficiency, to study the outcomes, and to automate all the segmentation process we described. Yeah. So this was a brief, I know it's super brief, overview of your paper, which I know it took a lot of work, but we wanted to give you the chance to explain how this process was for you.
Thank you very much, Sophia, and to the team for inviting us to join today for your journal club. That was an excellent summary. I think some of the discussions and questions we've received since publication, I can highlight here. So, your summary was excellent. Additional questions that have come up and that is helpful to clarify is, the intraoperative use and when you're wearing a headset versus not. And so this is a microsurgical case where you're wearing loops for magnification for parts of the flap elevation. And so it's not possible at this stage to be wearing an augmented reality headset and loops. And so it's very important to understand that these are used at certain time points during the case when making surgical decisions. And so the headset is used when detailed information on the anatomy would be helpful to move to the next step. And so I would put it on, 2 or 3 times maximum during a case. And I think the other important point to highlight is that it is intuitive. So it's intuitive for the surgeon to do gestures and manipulate the digital information by hand tracking, which is really helpful because in a sterile environment, I can't emphasize enough how necessary that is to make it part of your workflow, not disruptive and lengthen the case, but instead improve the efficiency. And so we're working now, we've completed over 25 cases, and we're working next to a RCT to objectively verify if this does improve surgical efficiency. Philip, did you have anything to add at this stage?
Just really great work, Sophia. I think you summarized it beautifully. I'm Philip Edgcumbe, radiology resident and one of the contributors to the paper. Tony Jiang's also on the call, who really took the lead on the software development side, and it's been great to work with him. I think it is just to highlight that piece about the surgeon wearing the glasses to kind of better understanding the imaging bring the imaging in 3 dimensions onto the patient is very important when it comes to operating. They're not operating with the glasses on. And I think that also opens up the avenue towards regulatory approval. It makes it a lot simpler because it's about we approach it as it giving the surgeon a better understanding of the imaging and the anatomy, but when it comes to the actual operation, they're not wearing it. And I think that's important.
Tony, anything to add?
I think all very valid points and great discussion so far. I'll leave the technical details alone for now. I think like if we have more discussion, it'll be interesting to bring up. For now, let's keep going.
Yeah, and I think some other, questions that we've received is, what are the future applications of this, and particularly for education, how could this be used for education? And I think, we developed this tool because we felt that there was important information in the CT that wasn't being used during the operation. You review it, you try and integrate the information to your decisions, and then you don't look at it again unless you unscrub and go back to the machine and review it on your desktop. So that was the motivation for this. But then obviously there's many other applications for this, particularly for fellows, residents in training, early career surgeons, or even later stage career surgeons. This can be helpful because it is a way of trying to get a better understanding of the anatomy, and it's never the same. So, I don't know that any of you are specifically involved in plastic surgery reconstructive cases, but for a patient, this anatomy is not standard. It's quite variable. And so that's why this was an excellent case where the high variability of anatomy makes it so fitting to have this detailed imaging available. For other types of surgeries where the anatomy is not that variable, it may not be as useful. But when you're training and you're trying to gain experience, you could gain it via augmented reality as opposed to per case in the operating room.
Maybe if I were to build on that when it comes to applications, I think the optimist and the very general perspective is if there's ever a point where the surgeon pauses and says what was on the CT scan and is just trying to think about what was on the preoperative imaging, that's potentially a useful application for this. So you could imagine it in almost many different surgeries. But then the slight contrapoint is this is displaying preoperative imaging. So it happens to be that an operation on the anterior abdominal wall is ideal because there's relatively little motion between preoperative and intraoperative. This wouldn't be necessarily as good a fit for something like a kidney operation where the patient is often imaged in one position and then they're on their side in the actual surgery itself, and there's appendicitis or something like that. So this happened to be an excellent application where understanding the detailed anatomy was important, and also the relative movement from pre-op to intra-op isn't that different. So maybe I could talk a little bit about the considerations we have as it relates to the CT scanning. Would that be of interest, Sophia?
Of course it will. Yeah.
Yeah. So I think for one, starting with the basics, when we're doing a CT scan with our patients, they're in a hospital gown and they don't wear, they're not wearing their pants, because you can imagine how that would change the anatomical, the anatomy. So starting with the basics there, that's important. The trend in medical imaging has been better, faster and better resolution, and that continues to be the case. So we worked with the radiology department at St. Paul's Hospital in Vancouver, and we specifically identified that we were going to use their newest scanner, because radiology departments often have multiple scanners, some of different qualities. So we're going to use their newest scanner. And we use something called their deep learning image reconstruction technique, which we found subjectively and objectively improved the number of perforators that we could see, the signal to noise ratio of the perforators relative to the abdominal fat. And then we timed the scan such that we trigger when we do the scan based on the contrast reaching kind of its maximum attenuation within the aorta. So those are some of the things that we did. And as I look forward to the future, there's a technology called photon counting CTs, which are coming, which are like another generational step forward, which are going to allow us to see smaller anatomy more accurately. At Vancouver General Hospital, they're currently installing a photon counting CT. I would imagine certainly in Boston, they must have a few. And so the main takeaway is it's going to get easier and easier to consistently see these small perforator arteries. And so that's another reason to be thinking about, displaying this information preoperatively or intraoperatively, because we can actually see it now in the preoperative imaging.
Can I ask a question that kind of builds on that whole workflow? Um, is in your standard workflow, do you image these patients preoperatively as hit even before this study? And then secondarily, one of the things that I thought was really interesting that your group did is some groups in the past haven't actually placed fiducials so they use existing CTs and then they try to register on an existing CTs. But one of the things that your team did, I think that was really excellent, was you put temporary tattoos and metal fiducials at the time that they were getting imaged, with the understanding that then you were going to use that information for your registration downstream. Um, can you talk a little bit about even getting patients to accept getting these small temporary tattoos? Because that's obviously an innovative way of thinking about imaging now, where we do preoperative imaging. So I'm a general surgeon and a trauma surgeon, we are doing preoperative imaging for surgery, but we're not actually doing this kind of metal fiducial or temporary tattoo placement for surgical planning as part of our imaging. I wonder if you could talk a little bit about that. Kind of even the time from the imaging to the surgery that you would have to have in order for the tattoos not to disappear, et cetera. Those kinds of things would be really, if you could talk a little about that, I'd be really interested to hear that.
Yeah, so we this was all done obviously in a research setting, and so patients were consenting to having the temporary tattoos.
Got
We
it.
went that route because we really wanted the reprojection to be very accurate given the size of the perforators. And so to achieve this high level accuracy, we landed on this as our final method for this paper. And it ended up being very successful because patients would agree to having the temporary tattoos because they wanted us to test the feasibility of this. They were very interested, and you know, all of our patients participate in a lot of projects as part of my lab, and so they're very informed, well educated, and interested in pursuing research, and so our patients are highly motivated. So from the consenting process, I would say that was very reasonable and not a large barrier. The CTAs we would always obtain because there's been lots of data to suggest that a CTA can improve the efficiency of harvesting the flap. And so at our institution, there's about 8 of us reconstructive surgeons, and we all use CTAs. So the time frame is generally approximately 2 weeks between the time of consultation and CT for an immediate reconstruction. So we would see the patient, consent them for surgery, order a CT scan, and somewhere between 2 weeks to 4 weeks is when their operation would occur and we would get their CTA. And so we knew that was the time frame that we had. And so we used the temporary tattoos and did them right at the time of the CT scan, or a couple days before the CT scan, and tried to time it so that there was definitely like 2 weeks between the tattoo and the operation, and it worked well. I would say that required coordination between our research team to make that an option, and I'm very grateful to all the coordination our team put together to make that possible.
And I would just say we did use a temporary tattoo pen that is just readily available, but you can also use like a permanent marker as long as it doesn't wash off. So temporary tattoo might be a bit of a fancy term. And the world of radiation oncology has a lot of experience in this because they'll scan the patient and they'll do multiple treatments and they're guided by the preoperative or the pre-treatment imaging. And so they have nice temporary tattoos. And so if you're looking for, I would say, innovation that's been really proven when it comes to preoperative to intraprocedural imaging, radiation oncology workflows are a good place to review the literature in or get some inspiration for. We kept it very simple with just these metal BBs, but it makes that registration very straightforward and simple because you see the same thing on the CT scan as you see on the patient's, anatomy. Or like the marking is the same. You can see that on the CT scan as you can see it visually.
And the tattoos were never gone, to just answer your question, they were always there. And then they faded after that, so.
I do have a question that is more like from your point of view, because it takes a lot of work to do all this workflow and, as you said, consenting the patient and getting the approval. So from your point of view, does all the intraoperative benefit justify the extraoperative preparation in your early experience in these 25 cases you've done?
Yeah, absolutely. I find that, I'm someone that loves to be able to predict when something is going to be exceptionally difficult. And the more I can prepare for a case, the better. And, many surgeons will rehearse a case in their mind before the operating room and then in the operating room. And so this is a way of not just simply rehearsing, but again, actively thinking about what you'd like to do next and using all the information available to you. So we felt that we were obtaining CTs on everyone. There's a cost and a risk to that. We need to optimize how we're using it. And so that's why, it's absolutely valuable. And next step is to prove it objectively by looking at, surgical times and safety outcomes. So we're going to objectively test it. But based on our experience in this small group so far, absolutely. And I would say that it's obviously at the beginning, there's many iterations to get to a workflow that works. And so once we've obtained that workflow that is feasible, it becomes easier with every case.
Thank you. Yes, I do.
Yeah, I would love to ask some questions.
Mhm.
Hello, my name is Dan. I am the PhD in Soroka Medical Center in Israel. Our team here is Dr. Meir Edgcumbe is the head of the breast reconstruction in Soroka Medical Center. And we have also Dr. Sukri, is the chief resident that promotes the extended reality in our hospital. So we are very interested in your work. We try to do similar things in Shiva Medical Center in Tel Aviv. And the difficulties that we are faced was most of the time logistics. I don't know how you're doing the annotation, if you do it manually or you do it with a computer. In our cases, it wasn't very accurate. And also, when we project the calibration on the patient, when we start the surgery, it moves and it loses its accuracy. So I was interested of how you do it, how you keep the accuracy during the surgery when the tissue is moving.
Yeah, absolutely. So the first thing relates to the accuracy that you mentioned. Philip briefly mentioned the CT scan and the resolution. And so early on, I would say that I would sometimes find perforators in the operation that were not identified on the imaging. But then since we did some work and improved our protocol and the quality of resolution of the CT, then that didn't happen anymore. So all of the perforators that we would see on the CTA, I would see in real time in the operating room. So if that is occurring, that you're not seeing the perforators on the imaging and you're finding more in the operating room, step one is to assess the CTA resolution. Second, we went through many iterations to place the fiducials in locations on the body where the soft tissue deformation is minimal. So that's why we picked sort of along the xiphoid, the pubis, where we're within the sterile field, but not physically where you are making an incision and causing deformation of soft tissue. Of course, there is some, but not to the same degree if you were closer and outside of bony landmarks. So we tried to pick places where there was soft tissue adhesions between the underlying bone, muscle, and overlying soft tissue. We still initially had a lot of challenges with just that. We would register, then, there's movement, and then you need to re-register again. Hence why we tried to make it such that the registration would just take 2 to 3 minutes. So that, let's say we would place the patient in the operating table, I would register, draw out the anatomy, or reconfirm the anatomy that I had drawn pre-op. I knew that as soon as the patient would move, like we would bend the bed, elevate the head, tilt the bed, that I would have to re-register. So it's just knowing that anytime you register the patient in that position, if you shift the bed or move the patient, you have to re-register. And so we tried to make it such that the registration process was short so that it didn't become something you had to repeat on every instance. Does that help to answer your question?
Yes, of course. And what about the annotation, the pre-op annotation? You do it manually, all the layers you mark them on the CT angio, or you have some automation that do it for you?
For this work, we did it manually.
Yeah.
ITK Snap has some semi-automatic segmentation, which we'll do initially, but and that can like automatically segment, let's say, part of the inferior epigastric artery. But when it comes to the perforator arteries, that's a manual process. The research assistant that does this normally takes about 2 hours per case to prepare it, and it's reviewed by Dr. Isaac and/or myself. And also we reconcile it to the radiology report, so that we also, something we could also share with you, I think afterwards, would be an example of the radiology plus report that we generate, where we help to, I think, help the surgeon understand where, when the radiologist says L2, you can actually see that in 3-dimensional space with the segmented anatomy. And so we do that additional reconciliation too.
Great. Thank you very much.
So going forward, one other question as it relates to those specifically, you talked about kind of auto segmentation, auto tissue segmentation, and it sounds like one of the issues is the need to re-register is it correct when you put on, for example, the headset, you need to re-register the set of images? Is there, just to ask Tony, is there work going forward to try to make that kind of persist across between sessions so that maybe, help with some of the efficiency gains kind of going forward?
Great question. I think registration is like the final battle for augmented reality, because like you need to correlate the virtual world with the real world in order for anything to be useful in the virtual world. So for this technology, there was persistence through sessions. If you can reasonably assume that the patient hasn't moved, you can't always do that. And we made sure that Dr. Isaac, when she was doing her cases, to tell the anesthesiologist to not move the table, at least like not move the patient as much. But going in the future, like we are trying to make it so that the registration process can follow the patient, and a core component that is probably like point cloud matching. And I think that would be the gold standard of projecting dots and measuring like the deformations, and like that kind of also goes into soft tissue. So in brief, like, yeah, we are trying to, it does persist through sessions, but a more accurate way to do it would be to register in real time instead of rely on that assumption that the patient hasn't moved.
Let me just ask one follow-up question as it relates to that, just because that's one of the areas that we're thinking a lot about is in order to think through that point cloud registration effort, are you leveraging the existing imaging that's in the MetaQuest 3, or have you thought about using external sources of imaging, cameras, even an iPhone camera that also generates point clouds. How are you thinking about the relationship of kind of building SLAM and ongoing registration capabilities kind of as part of this?
Um, you don't have like sensor level access to the Quest 3. So the sensors are locked down and we're not able to utilize. So like we have to go through an approach of using external external sensors that allow us to register and like protect the point cloud and get the feedback. So you do need some kind of stand or some kind of station in order for that to happen. And like I have been contacting like Meta and Apple asking for like lower level access to sensors, and like that has been an ongoing discussion. But like for now, I think the way to do it is to use at least to validate the point cloud idea using external sensors before we actually have permission to access the sensors on the headset.
Got
I
it.
know there's the Surgical Information Lab is very well known. So if there are Quest and Apple Vision or Apple employees watching this recording afterwards, please feel free to reach out. We'd love to have access to those sensors. And I think that's an area, whether it's with us or others, which would be important for exploring, how to use those sensors for that surface-based tracking. And I guess to build Dr. Pratt on one other point is if you do the registration and you're confident that you've done the CT to patient registration and you just need to track patient movement, there are potential other solutions like you could put a QR code on the patient and as long as it's rigid and you're confident that it's not moving relative to the patient, then you could then track patient movement relative to your initial registration. That could be another workaround, and there's varieties of solutions in that kind of neighborhood that could be explored as well.
This is fantastic. I just want to make sure that because we always have a tendency to go over rather than stay to time. So we're gonna be respectful of your time. And Sophia, do you have any last thoughts?
Mm, I just wanted to thank you a lot for first being here and making the time and everything. We're really grateful. I think this was extremely productive and it also like helped us understand better. I've been like reviewing papers for this review, but still it's not the same as having your first perspective, which was super helpful. So thank you for that. And also I wanted to thank you for being open to this kind of technologies. It is normal to encounter a lot of resistance when talking about these topics because even without these surgeons do this surgery. So they are like, why do I need this for? It's like, and of course, the reasons are huge, and you mentioned a lot of them, and it improves outcomes, it improves your confidence, it makes you more prepared preoperatively. So thank you for having that like that state of mind and pushing this forward and reporting and so on, because I think it's super helpful and it speaks greatly. So thanks.
Okay, well, thanks everybody. Thank you so much for taking the time and everyone have a great morning. Good luck with your case.
Thank you, everyone. Have a lovely afternoon.